Before I introduce our speaker, there are some housekeeping items I just want to take care of for broadcasting. As you know, we are broadcasting live via live stream and YouTube. Uh, the audience here, please use the microphones to ask questions. And for those who are not here, the recording is always available for viewing. And I would encourage prescribing to our YouTube channel to get notifications when these new videos are added. For our viewers, if you'd like to submit a question, text DeBakey to 37607. You can also submit question via the live stream feed. Find the video on livestream.com/hmh-edu. And for our next conferences, we are having a robotic vascular surgery summit, March 25th to 26th. Heart of a Woman, April 27th, and Cardiovascular Disease Prevention Symposium on May 4th. So, and then again, it is an honor and true immense to introduce my dear friend, colleague, Dr. Sadeer Al-Kindi, who brings with him a diverse set of expertise. He received his MD from Weill Cornell, Qatar. And from there, his journey pursued with a training in internal medicine, cardiology, cardiovascular imaging, translational science at Case Western University Hospitals in Cleveland. He stayed there in various roles, leading cardiometabolic health, imaging, big data, and so forth. We were extremely fortunate to attract him to Houston this summer as the Associate Director for Preventive Cardiology, as well as Associate Director for the Center for Cardiovascular Precision Health. He's also a valuable member of our cardiovascular imaging cohort. In a short period of time, he has amazing academic productivity with more than 200 papers, but I would say it's not the numbers, but truly that make him distinct is the impact of the work. And why do I say that? Just from prevention standpoint, historically we have all focused on traditional measures of risk and management. And Dr. Al-Kindi has been at the forefront emphasizing that if we truly want to maximize our yield, we have to break down the silos and look behind the confines of the healthcare system. And in this regard, his groundbreaking work has truly focused on the complex findings on, I would say, your neighborhood health at the intersection of social risks and environment, which I feel has the potential to go beyond the domains of cardiovascular disease. So, and as a result of all of the potential and the impact, he was also inducted as the Gerald Katz investigator in the Academy of Translational Science to support his novel high-risk, high-reward work. And without further delay, I will have Dr. Al-Kindi enlighten us that why everyone in healthcare, and especially in cardiology, needs to start thinking about environment and what's the future holds for us. So, Sadeer, please, welcome.
Thank you, Khurram, and thank you everyone for joining and for the invitation to present. Just going to make sure that we see the slide here. Okay. So the objectives of this talk, I'll be talking about the interconnections between planetary health and cardiovascular health. And hopefully this will be a little bit more clear at the end of the presentation. But the objectives of this talk, we're going to try to understand the impact of the environment on cardiometabolic health or cardiovascular health or metabolic health. We're going to try to understand the concept of the exposome and its relationship to health outcomes, specifically cardiometabolic and cardiovascular risk. We're going to try to understand the flip side, so the healthcare impact on planet health. I'm not going to spend too much time on this, but we'll touch upon it. And then understanding the concept of urban design and how does that link to cardiovascular health, and trying to get outside the clinic to understand community health. And I realize this is a topic that it's not necessarily something that we talk about all the time as clinicians, but it's very, very important, and I'll hopefully convince you at the end of this talk that it has significant implications even in clinical practice. So one of the things that attracted understanding and delving into this topic is really, if you were to look at cardiovascular mortality in the United States, this is an age-adjusted cardiovascular mortality in the United States, and you can see that there is approximately 10-fold increase or difference between the highest county in the United States and the lowest county. Of course, some of this could be related to access to healthcare, insurance, and so on and so forth, but we all know that this is not the entire story. It does not explain tenfold increase in age adjusted. So this is after adjusting for age. So it's not accounted by just even aging of the population. So that really kind of, I looked at this, and this is one of the analysis, the initial analysis that we started to do. And I wanted to understand really what describes, what explains this variation, because this does have implication. And if we were to move these areas, or people who live in these areas, to areas like this, then we've done our job and kind of, reduced cardiovascular mortality in the United States and improved cardiovascular health. And you can see the same story even when you look at veterans. For example, in the United States, we look at cardiovascular risk factors. So uncontrolled blood pressure, uncontrolled diabetes, obesity, and depression. All of these have significant geographic variation that is not really just explained easily by aging of the population, neither is it explained by access to healthcare. So that's something that really intrigued me, and I wanted to try to understand some of these concepts. This notion actually also expands globally. And if you watch Netflix, this is an amazing series that talks about these blue zones in the world where people live up more than 100 consistently over generation. So there's something in these regions that makes these regions resilient. People are living healthy, they're living longer, and they have, significant, they're the outliers in lifespan. And it's not just cross-sectionally. If you were to look at series of people, and this is from the VA where people, we have EHR data that dates back to the 90s. If you were to look at people who moved from one neighborhood to another neighborhood, very interesting. If you look at, for example, uncontrolled blood pressure, if you move from an area that has low levels of uncontrolled hypertension and go to an area that has high levels of uncontrolled hypertension, you adapt to your new environment. So you are more likely to have uncontrolled hypertension when you go into the next area. And the same thing goes to obesity, same thing goes to depression and uncontrolled diabetes. So there's something, even longitudinally, when you move from one area to another, that can explain some of these impacts on cardiovascular health, which is something that we don't talk in clinic about. We don't, we have the zip code in front of us in Epic, and we have no idea how to interpret that or what does it mean for us. So where you live matters. I think, all of this is cool and longitudinal studies and everything, but to me what cemented it, this is a randomized trial. To me, this is one of the smartest randomized trials. This is a trial of people. This is sponsored by the Department of Housing and Urban Development. And what they did is they took women and children who live in high poverty areas, and they randomized them to either giving them a voucher, a housing voucher, or giving them nothing. And if they give them the voucher, they told them, you only get the voucher if you move from where you live in high poverty area to a low poverty area. And this is in a randomized fashion. Of course, about 5,000 people were randomized, and they looked downstream of that kind of intervention, which was a social intervention, so to speak, and they looked downstream of incidence of diabetes and incidence of obesity. And what you find is, that at about 10 years, you'll find that the prevalence of obesity as defined by BMI is much lower, the prevalence of severe obesity is much lower, and the incidence of diabetes is also much lower, right? So this tells you that there is, now we did an intervention, we found some outcome, there is some causal pathway that links, and this is not just a coincidence or correlations that we're seeing ecologically. So we have to realize, as human beings, individuals, we live not in silos, we live in a community, and we're exposed to various exposures, both environmentally and socially. So you can see that we're exposed to the climate, we're exposed to the air quality, food networks and food environment around us, light pollution, noise pollution, temperature, and also the social environment around us. So, like I explained about the cardiovascular risk factors and how people adapt to the environment around them. But also now we're overloaded with all this information, radiomics, kind of looking at imaging, looking at social networks, understanding genomics, understanding metabolomics. So that's really what intrigued me, and kind of understanding how can we take a step forward to understand cardiovascular health within the context of what I call the exposome, which is the exposure, the totality of the exposure. And this is only in one time point. This is a kind of a snapshot. But if you think about this over the ages, since you were born, even in utero, until you're in your older age, this has significant and tremendous impact. So as you know, the American Heart Association every few years come up with this concept of essential 8, or these are factors that we need to control to live happy, healthy. And for the first time this year, or 2 years now, they started to think about social determinants of health as the drivers of cardiovascular disease, and something that is modifiable to a certain degree. But I would take this a step further, and I would think about the environment, the exposome, right? So the exposome could consist of the external exposome, and this is what you're exposed to in your environment, including green space, noise, light pollution, air quality, of course, urban environment. Your personal exposome, and that includes your diet, your physical activity, even your social networks and your smoking and sleep habits. And then how do these interact with your biological responses, right? So if you have metabolome, right? If you have the microbiome, how does that work? How does that intersect? If you have some genetic predisposition to disease, how does that interact with the environment? And this concept of the exposome is critical to understand the totality, and also to humble us to understand that we don't know quite a bit, right? There's a lot that we need to know and we don't know, and it shapes our health and cardiovascular disease. So we have, ever since medical school, we're always thinking about cells and disease and heart and looking at the vessels, and even throughout our residency and training programs and research and so on and so forth, and we've always been cardiocentric. And when we kind of think a little bit more more globally, we start to think about these life essential 8, right? You can think about blood pressure, diet, exercise, and so on and so forth. And more recently, you've heard from Dr. Libby a couple of weeks ago about residual inflammatory risk and residual thrombotic risk. So with the trials that came up with Pegasus, Compass, and Voyager, we're understanding that there is residual thrombotic risk that we still have, even after controlling all of these, smoking cessation, healthy diet, there is still some stuff that is residual, and that can be attacked by antithrombotic medications, for example. And there is also a residual inflammatory risk. So these concepts of residual inflammatory and thrombotic risk are emerging concepts given the trials and so on and so forth. But I would say that there is actually residual social risk and residual environmental risk that we don't think about in clinic. We don't think about as clinicians. So I coined the term residual environmental risk, or residual socio-environmental risk, to really help us understand and capture that concept, and understand that there is, even after you control all of this, put patients on medications that control their thrombosis risk and inflammatory risk, there is still some residual risk that is captured by the environment, that is captured by the social determinants. And hopefully I'll convince you in the next few slides about this. So let's start with air pollution and air quality. Air quality and total pollution actually accounts for more deaths, if you think about it globally, than all of the other problems listed combined, right? So it accounts for more deaths, cardiovascular and non-cardiovascular, than alcohol abuse, AIDS, malaria, and infectious disease, road accidents, drug abuse. So it accounts for about 9 million to 12 million deaths annually in the world. Of those, the vast majority are accounted by air pollution specifically, not total pollution. When you look at air pollution, when we try to understand air pollution, and this is an emerging topic, and kind of you'll hear more about it in the news and everywhere, air pollution, the most important air pollutant is something called particulate matter. And I usually explain air pollution as two components. One is a gaseous component, and one is a solid component. The solid component is really that small particulate matter, which is, these are very, very tiny aerosolized kind of airborne particles that are measured by size. So we measure them by microns, 0.1 micron, 2.5 micron, or 10 micron. And this gives you the size kind of spectrum as relates to cells and things that are familiar to us. So PM2.5 is probably the most important, the most studied, the most impactful when it comes down to health outcomes, specifically cardiovascular disease. When you look at annual exposure and concentrations in the United States and globally, there is significant variation. And you can see that in the North Africa, Middle East, and South Asia and East Asia areas, there are significantly higher levels of air pollution as can be expected. Most of this air pollution actually is human-made. So most of it is what we call anthropogenic. And you can see here, for example, in the United States and the Western world in general, we live at relatively lower air pollution levels. But that, although that's a good thing, that's not there is no safe limit to air pollution. So if you were to look at the relationship between air pollution in the x-axis here and the relative risk of cardiovascular disease, this is from hundreds of papers, multiple meta-analyses, it shows you that it's a curvilinear relationship, that there is no safe limit, and it goes all the way down to 0. And interestingly, it's somewhat curvilinear probably, because what you do see is that a steeper curve here, suggesting that there is implications here to reduce air pollution on the hazard ratio or the relative risk of cardiovascular disease health outcome that is more impactful in the lower areas than the higher areas. Of course, if you are very high here and reducing it from 120 to 60, that's still significant. But if you were to reduce it from where we live here in the United States between 10 and 20, and sometimes even less than 10, all the way to 0, then you have a more relative increase or decrease in cardiovascular outcomes. Interestingly so, most of the literature, before I started kind of looking into the literature, most of the literature has been derived from studies that looked into patients who are healthy, and they followed them up for incidence of myocardial infarction or cardiovascular death. So I was really interested in understanding how do our patients with pre-existing cardiovascular disease fare when they are exposed to air pollution. So one of the first studies that I did was looking at the UNOS study, UNOS registry, which is basically the solid organs in the United States. And after getting some permissions and so on and so forth, we linked all the patients who received heart transplantation with metrics or measures of air pollution that is ambient, annual. And we showed that there is a semi-linear relationship between particulate matter exposure, and you can see the levels here on the lower side compared with what I showed you in the previous slide, because that's in the United States only, and the hazard ratio. And if you see, for example, where there are areas people living in about 16 or so, for example, Cleveland, Ohio sits about 12. There are some areas in the country that have about 12 to 15. The hazard ratio as compared with areas that is very low, about 6 or 5, it's about 1.26. About 1.5, right? And for each 10 microgram increase, there's about 1.26 increase in hazard ratio. This is not minimal. This is something that is really dramatic when we talk about mortality in patients who have heart transplant. This is equivalent to some of the new immunosuppression, some of the newer techniques in heart transplant. So the differences are not minimal. The differences are huge. We don't think of them as big when we talk about air pollution. We think that this is not a problem in the United States. But this tells you that after adjusting for various things, including immunosuppression techniques, including the surgical techniques, including even socioeconomic status, there is significant variation. And it turns out that when you compile the prior studies that looked into incidence in primary prevention and secondary prevention and so on and so forth, the patients who have heart transplant, they're really kind of the outlier, so to speak. So this suggests that the patients who have pre-existing cardiovascular disease, specifically in this study, patients who have heart transplant or undergone heart transplant, they're a little bit more prone to the effects of heart transplant, of air pollution. The second thing that we looked into is really patients who have pre-existing atherosclerosis, and somewhat of a severe atherosclerosis phenotype, who underwent elective stenting. So the best studies oftentimes to look at this is the national studies, and in the United States we don't have, like in the UK or some of the other European countries, we don't have global registries or national registries. So we used the EHR data from the VA, from the Veteran Affairs, because it's a national study. The patients are we have the residential addresses and so on and so forth. So what we do find is we took about 73,000 veterans and linked them with measures of air pollution, PM2.5, and we show that if you have a stent when you're 50 years old, as compared with the lowest number of basically air pollution, for each 10 microgram increase in air pollution, which is equivalent from going to one of the smallest or lowest exposed areas in the United States to the highest exposed areas, you have about 0.5 to 0.7 rate increase in incidence of myocardial infarction or MACE events in general. So you lose approximately significant amount of your life just by living in a high exposure, specifically if you start living in these exposures at younger age or you get stent at younger age. The same thing applies for patients who receive coronary artery bypass grafting. This is a recent study about 26,000 veterans who underwent CABG, elective CABG, and we linked them and we followed them we linked them with air pollution metrics, and we followed them for incidence of MACE as defined by myocardial infarction, stroke, or cardiovascular death. And we showed the same numbers, approximately for each 10 microgram increase, which is reasonable in the United States, you do see a 27% relative increase in MACE. And that's something that is equivalent to a lot of the, we argue all the time about CABG versus CABG versus PCI, Plavix versus ticagrelor, this versus this. This is probably in the same magnitude of effect as compared to some of these medical or surgical interventions that we do for our patients. Not only that, we estimated that about 10% of the total MACE in this population can be attributable to air pollution, PM2.5 variation in the United States. This is even in the narrow range that we do see in the Western world. And if we were to reduce the PM2.5 in the United States from where it is right now, which is on the lower side, to where we need it to be, which is 5, that's what the WHO, the World Health Organization, tells us, then we would have a 7% absolute reduction in 10-year MACE, right? So 7% absolute risk reduction, meaning that we have a number needed to treat of about 13 to actually prevent one MACE event. This is not only fun and games when we talk about ecologic studies and we talk about epidemiologic studies. This has been significantly studied in basic science, in experimental human studies. It's been studied in using some of the novel emerging techniques, cellular and mechanistic studies. And what we know right now is that air pollution can lead to significant impact on various organs and tissues. So adipose tissue is one of them, immune system, of course, and that could explain some of the effects that we did see in the heart transplant cohort. It also impacts liver, it impacts the muscle, brain, you name it. And there are significant, I'm not going to spend too much time, but you can read that review paper that just got published that shows you really kind of delve into the understanding of what we know right now in terms of molecular, cellular, and physiologic changes that happen with air pollution, and how does it impact cardiometabolic risk in patients with or without type 2 diabetes. Now, switching gears a little bit, although most of the literature has talked about air pollution, noise and cardiovascular disease have been significant linkages, both in mechanistic studies, intervention studies, and epidemiologic studies. So just to give you a perspective, we measure noise by decibel, and you can see, for example, there is, even rain can cause some, and you can see that the unhealthy limits is where we get to passenger car, telephone ringing, and so on and so forth. What's interesting is transport-related or airport-related, both car and airport, airplane, aircraft-related noise has been linked significantly with cardiovascular disease. So this is a couple of analyses here that shows you that the hazard ratio for ischemic heart disease goes up significantly when the road traffic noise exceeds the healthy limits that we define as between 60 and 70. Same thing goes in with the stroke. So, and it's somewhat of a threshold. There is a threshold effect. So you're okay if you live in areas or you're exposed to low noise. So think of this when you go to the ICU and you round on your patients. What is the impact of this on our patients? For example, the bells and whistles that we do here in the ICU. And how does that really impact patients, for example, who live nearby aircraft or airport and exposed to aircraft noise? The same thing when you look at the UK Biobank, which is a huge study of about 500,000 people, and you follow them up. Exposure to road traffic noise can be associated with increased incidence for primary hypertension. And even in field studies, when you basically do simulated noise in the bedroom for individuals, relatively healthy individuals, you take them and you randomize them to simulated noise using a speaker in the bedroom at night versus no speaker. You do see there is significant impact on endothelial function, blood pressure, restfulness, quality of life, and of course, sleep quality. So all of these factors have been, of course, associated with cardiometabolic health. So, thinking about noise can be important for understanding cardiovascular disease. Now, the concept of the exposome came by because we started to understand that there is actually interaction. These effects are not just additive, but they're interactive. This is an example of looking in the United States at age-adjusted cardiovascular mortality. And you can see we basically looked at the relationship between PM2.5 exposure on the x-axis and age-adjusted cardiovascular mortality in the y-axis. And we simply looked at people who have low socioeconomic status, which is on the right side, high social deprivation, and high socioeconomic status, which is on the left side, which is low social deprivation. And you can see that the shape of the relationship, first, it's linear. Second, it's more steep in those who are exposed to high social deprivation. Suggests that there is an interactive effect, interaction between or heterogeneity of the impact of PM2.5 on individuals by socioeconomic status. So how can we try to understand all of these in conjunction and understand the concept of the exposome? Now, I'm just going to touch on a couple of other exposures. I'm not going to go through everything, but just to show you that there are other exposures that are very, very important. So built environment, as measured by, for example, neighborhood walkability, how walkable your neighborhood is, as measured by number of intersections, whether the presence of walk paths and so on and so forth, has significant relationships, at least ecologically in the United States, with cardiometabolic health. So you can see as the walkability increases, there is less blood pressure, less high cholesterol, less obesity, somewhat less diabetes, you can argue about that, but less coronary artery disease. And some of the effects on coronary artery disease, or the relationship between walkability and coronary artery disease, can be explained by, mediated by the impact on high blood pressure and high cholesterol, obesity, and diabetes. But there's some residual effects that we don't fully understand. The same thing, this is work from here, the same thing that looked at the food basically environment. So there are metrics where you can actually measure the quality of the food environment, and the higher the food index, the worse the food environment. The lower the food index, the worse the food environment, as measured by access to healthy food and so on and so forth. So as you can see here, and this captures it here, is if you have higher food environment index, suggesting better access to healthy food, you have lower risk of cardiovascular mortality. But that relationship is steeper if you have higher income inequality compared with those who have lower income inequality, suggesting that if we do intervene on those who have higher income inequality, we have a better impact on cardiovascular health. Of course, this is still ecologic and so on and so forth, but this fits with the paradigm that we see in individual studies as well. There's no, I cannot go through a presentation without thinking about climate change. And climate change, as you all know, I'm not going to go into deep details about this, but really climate change, as you know, it's a process that is slow, but it's alarming right now because it's basically fueled by fossil fuel use and by anthropogenic activity. Part of it is really changes in temperature. So temperature has been linked both mechanistically and epidemiologically with cardiovascular disease. Again, not something that we think about other than the person who shovels snow and gets a cardiac arrest. But in reality, there's actually significant impact. And we estimated globally about 1.2 million cardiovascular deaths in the world happen annually because of what we call suboptimal temperatures, both high temperatures and low temperatures. Of course, as you can imagine, there is a significant global geographic variation in this, with Middle East and North Africa have the lion's share of hot heat-related temperatures, while Siberia and part of the North Asia have significant impact of low temperature. But you can see the trends are really concerning, right? You can see this is from 1990 till now, and you can see that there's increase across the board, the number of deaths, but also the DALYs, the disability adjusted life year, which is a measure of morbidity of cardiovascular disease. So you can think of it as, basically both temperature, low temperature and high temperature that can cause really it's badness that is going to happen, and it's an impending badness that's going to happen that's going to even worsen the epidemic that we're experiencing right now. So we talked mostly about adults, but thinking about the exposome, you're exposed to it in utero, and then you, as an embryo, fetus, infant, child, adult, and older adult, that can actually shape your health, and both from a cardiovascular risk factors on the y-axis and cardiovascular events, of course, which happens later in life. But you can think of all of these factors of the exposome: temperature, green space access, sleep, and air quality, and so on and so forth, which can shape your health. And if you have a healthy exposome versus an adverse exposome, that can actually help you live longer but also live happier and with less risk. So oftentimes people talk about the exposome as a bad thing, you're exposed to bad things, but in reality there's also this part, the beneficial part of the exposome. Think about green space access, right, or parks access. If you have stress resilience, right, that's part of the internal exposome. If you have immuno and redox balance using some of the supplements potentially or some of the genetic predisposition to some of these things, that can actually be helpful. So how can we balance and how can we really invest in the beneficial part of the exposome? How can we, for example, exercise, have access, go to the spa, whatnot, eat healthy, to kind of balance and counterbalance some of the bad effects of the exposome? So I've showed you, for the most part right now, individual components of the exposome, but I hopefully convinced you that the exposome components can actually be interactive and can be additive to each other. So we started to use some of the data science approaches, emerging machine learning approaches, to try to understand and rank and kind of look at the intersection between some of these factors. So this is one of the first examples or proof of concept where we look at the premature cardiovascular mortality in the United States, and it looks, there is similar to the previous maps that I showed you, there is significant variation. And we asked a simple question: what can explain this variation? And we basically have a myriad of exposure variables, including socioeconomic but also environmental. And you can start to see things that are really interesting. This on the right side of the curve here, you can see this is the importance of these variables as they relate, the strength of the relationship when they're added all together. And of course, income and poverty come at first, but then you start to see things that are interesting from an environmental exposure. So food insecurity, even broadband access to the internet, SNAP benefits, and that part of this food security as well. You can start to see that there is air toxics show up here in the top 15 or so, access to exercise opportunities, and so on and so forth. So this kind of proof of concept pipeline helps you understand and rank and try to understand what is really important in these relationships. It turns out that vast majority of studies, they look at the national as if that the same concept, for example, PM 2.5 can actually impact the entire country in the same way. That is not true. It turns out that there are some pockets that can be impacted. And this kind of exercise is called geo-weighting or geographic weighting. It helps us understand pockets of areas where there is significant intersection between exposure and outcome. This is cardiovascular mortality, and you can see there are some areas that are where PM 2.5 is playing a big role versus areas that are primary healthcare access is playing a big role. And this helps us understand the impact of the exposures, but also helps us to kind of perhaps test some policy interventions that can be localized. Not the same policy intervention can work throughout the country, but there are some localized policy interventions, and this gives basically the power and gives the incentive for local policymakers to change their communities and in an attempt to improve health. Not only that, when you do look at the different pieces of intersection, the internal exposome is as important as the external exposome. And what we did here, for example, we took exposures. This is about 155 at this level, where everything that from food security, food environment, to air pollution, to noise pollution, to even light pollution at night. And we linked them with a cohort of individuals that underwent calcium scoring. These are healthy, relatively speaking, people who are primary prevention. They have some risk factor for cardiovascular disease. And as you can see, as expected, if you have, and follow them up for MACE. As you can see, CAC here, if your calcium score is 0, you have absolutely no events. And then as your CAC increases, the event rates goes up, as been shown by multiple people, including Dr. Nasser. But what's interesting here is when you combine these exposures and you create a singular socio-environmental score or an exposomic score, you can see that across the board in any category of calcium score, as your socio-environmental risk or exposure gets worse or adverse exposure gets worse, you get a higher risk of MACE. So how can we reclassify, for example, these individuals who are relatively, for example, 1 to 99 as an example, how do we classify them from being low risk, which we consider them to be low to intermediate risk, to a high risk just by taking their environment? So this brings in the residual socio-environmental, residual exposomic risk that can help us fine-tune prediction and understand risk in the clinic. Now, one of the other things that the built environment has really significant impact. Everybody here knows if I show you a picture of a neighborhood versus another, you can probably have a sense of how bad the prevalence of coronary disease risk. But how do we really capture this? And one of the things that we thought to do, which was not done before, is really taking some of the publicly available data from images of people's homes, neighborhoods, and so on and so forth. So you can see, for example, here is a satellite image, Google satellite image, which is available most of the world, if not all of the world, and then Google Street View images, which gives you a little bit more a zoomed in version of your neighborhood and your home and so on and so forth. Using some machine learning computer vision applications, now you can actually try to understand what is happening in these images, extract variables, features, and so on and so forth. And what we wanted to see is to what degree do the variation in these images explain that variation that I showed you in the first slide? Do they explain the variance in coronary heart disease? So we took an example of about 7 cities, and you can see that the observed coronary artery disease prevalence and the estimated coronary artery disease prevalence by this machine learning on images, they correlate very nicely. So about 60% of the variation in coronary artery disease prevalence in these cities, in these neighborhoods, about 700 neighborhoods, can be explained by findings on these images. And these findings, and you can see, for example, here are maps where what is observed in cardiovascular disease or coronary artery disease prevalence. This is what's been predicted by the satellite image, and this is what's predicted by our model, which is Google Street View image. And not only that, but you can also highlight and pinpoint in these images what is really has been linked or associated with these risks of coronary artery disease. So it gives you a hyper-local, fine-tuned map on what is really, now again, these are associations here, so we don't know about causality, but it can give you an insight into what is really has been associated using a data science approach, which can be then fine-tuned to understand policy interventions. So I'm going to spend a few minutes here on future opportunities and path forward, and I'm going to try to understand them within the concept of individual, society, and healthcare. The impact of basically the concept of the interconnection between planetary health and cardiometabolic health is very complex, as you can imagine. This is a nice paper in Lancet a few years ago that looks at the syndemic of obesity and climate, right, in planetary health. And you can see all these feedback loops that are very complex. But these are, because this is not a simple problem, you have to think within systems approach or systems thinking to understand what drives what, because it's not a simple intervention that can help improve things at the same time. So you can see there's health loops, there are governance loops, there are business loops, there are supply and demand, and ecologic loops. And there is, of course, the players here. There's a parent, an employee, and customer, voter, and walker. And you can see some of these layers of family communities all the way down to natural systems. And so basically, it's a concept that is very complex, but you can probably think about it as a microsystem, mesosystem, and a macrosystem, kind of different layers of or shells of the same sphere, so to speak. So let's start with the individual. What can we as individuals do? And I showed you this residual and inflammatory and thrombotic risk and how we can capture residual social risk. But that's one of the things that we can do and assess in clinic. Part of it is probably attainable at this day and age and using some of the publicly available data, but some of it could be also individual kind of questionnaires looking at SDOH and environmental hazards. But why is this important? One of the questions that I get asked whenever I give talks like this is, why do I care as a clinician? I'll tell you one example that we looked at is that environmental risk can actually intersect with the treatment effect. This is an example of what we did. We looked at a trial called SPRINT trial. This is a large trial of about 10,000 people where people at high risk were randomized, multi-center study, NIH funded. They're randomized to an intensive blood pressure control versus usual blood pressure control using some of the available therapies. And of course, the trial was positive, and the hazard ratio in that trial was about 0.75 to 0.8, depending on what outcome. They followed these patients up for incidence of myocardial infarction, heart attack, stroke, and other things. So we asked a simple question. If we were to assign exposure by PM2.5 to all of these individuals, what do we see with respect to the impact of the treatment? So we took these individuals. Of course, that was a very, very difficult thing to do because zip codes and analyses were very PHI controlled, so this took about 2 years of work. But basically what we did is we linked every single individual in that study, about 10,000 individuals, to air pollution exposures assigned by satellite, and there's novel metrics that you can do. And then we asked a simple question: is there an impact of intensive treatment in those who are exposed to high air pollution versus those who are exposed to low air pollution? And this is critically important because part of the impact of air pollution is mediated through blood pressure increases. So that's why we went to the SPRINT study. And what we found was really interesting. One is if you are exposed to low air pollution as defined by the EPA thresholds at the time, you still benefit, and the hazard ratio is 0.81, and you can see the intensive treatment led to less impact of more reduction in terms of cardiovascular outcomes. But what is interesting is if you live actually at high air pollution levels, your intensive treatment benefited you significantly more. And you can see that even there is a positive interaction, statistically significant interaction, to the point that the hazard ratio here is 0.46. So just by controlling blood pressure in those who are exposed to high air pollution, you can halve their risk of cardiovascular events. There are actually AHA statements that looked at personal protective actions against particulate matter specifically, and this, the optimal impact can be defined. It has to be practical, safe, and low cost or no cost. They lay out the kind of the different exposure, different kind of interventions that we can do. Portable air cleaners is one of them. Face masks, specifically N95 or N99 respirators in patients who are high risk. There is air conditioning kind of filters that you can put in, HEPA filters, and if you're driving in a car, closing the windows can have significant impact. All of this is evidence-based, supported by, some of them are actually randomized trials, believe it or not. And they lay out, the approach that we can see in clinic in terms of prevention and so on and so forth. This is a meta-analysis of randomized trials that looked at portable air cleaners. These are, $50 that you can put in your bedroom or in your living room. And most of these studies have been done in China and India, but some of them are actually done in the US. And you can see that portable air cleaners leads to significant reduction in blood pressure, even when it's used for a short period of time. So this is as an adjunct to some of the therapies that we can utilize. And it may have significantly more impact in countries or cities or areas that are exposed to very high levels, including in California where you have wildfires. We are actually testing this hypothesis and understanding the mechanisms of this in Qatar. Qatar has one of the top 5 countries where they have high exposure to PM 2.5 for a variety of reasons, and we're doing this in patients who are susceptible to impact of air pollution. So these are relatively younger individuals who have some elevated blood pressure but also have metabolic syndrome, and we're doing an active filtration and sham filtration using portable air cleaning in a crossover study, and understanding not only the impact on blood pressure and metabolic biomarkers, but we're also testing epigenetics and single cell analyses to understand really the cellular underpinning. So this is an ongoing study. Some of the personal mitigation approaches beyond home air filtration is obviously avoiding polluted environments, and that's where the air quality index alerts that come in handy. Reducing your exercise when the air is polluted. There is some evidence, again, I'm not supporting this yet, but there's some evidence supporting the dietary supplements, especially as it relates to high exposed individuals who have some redox imbalances, and of course staying indoors and personal face masks. Now, healthcare, spending maybe 5 minutes on healthcare impact on the environment. So that's kind of the flip side of not environment on health, but healthcare on the environment. And it's not a surprise to all of you that we waste a lot of things, right? So this is during COVID. You can see all these face masks in the landfills and the tubing and whatnot. And interestingly, if you were to look at global greenhouse gas emissions, which is a metric for how we are polluting the environment, the US, as it does in every other field, it contributes to a quarter of the global greenhouse gas emissions that is related to healthcare, right? So let that sink in. The US alone is contributing to 1/4 of healthcare related pollution in the world. So that's something that we ought to do, and we have to take the leadership here in the U.S. Greenhouse gas emissions can be divided, somewhat arbitrarily, but the concept here is multiple scopes related to healthcare delivery, manufacturing, and actual use of energy and things like that in the hospitals and healthcare. And you can see that waste management, transportation, pharmaceuticals, and so on and so forth, there's significant, basically all of these factors can contribute significantly. So in cardiovascular, it's no surprise that because cardiovascular disease is the #1 killer in the United States and globally, then we have a lot of devices, we have a lot of things that we do in cardiovascular disease. So the combination of these two can actually make cardiovascular field, both surgical and medical, to be a major polluter and major contributor to this. So transportation of patients and staff, pharmaceuticals, food even for patients and staff, energy use in the cath lab. You go to the cath lab, it's freezing cold, right, even at night. Medical devices, we throw a lot of stents that are 1 day old or 1 day past the expiry date. We throw a lot of ICDs and probes and so on and so forth. And of course, there's single-use disposable. So how can we solve this, and how can we move from where we are right now to sustainable cardiovascular care? Of course, it's complex, but starting with systems thinking, we have to change the culture. We have to educate our fellows and residents and medical students about sustainability and how can we care for the environment at the same time as caring for our patients. But also, I think, of course, I'm biased, but I think prevention of cardiovascular disease can lead to less stents, less bypass surgeries, and less masks used, right? So how can we think about prevention a priori? And it goes back to full circle here, right? So you care about the environment, which helps with reducing, improving prevention, and it goes back to reduce impact on the environment and so on and so forth. And of course, how can we, attack, so to speak, or intervene on poverty, nutrition, education? We need technology innovation. So how can we understand, for example, how can we reclean some of the single-use things that we do, and evidence-based clinical practice. So for example, one of the things that, waste in medical use, right, on testing and so on and so forth. We also need to understand how can we recycle some of this. There's actually a lot of evidence that ICDs and pacemakers can be reutilized after proper cleaning. Can be from, when a person dies, it can be explanted and reimplanted in another individual. So a lot of this is hopefully, the next generation can solve a lot of these problems. This is a conceptual framework to understand this in the cath lab specifically, because the cath lab and the EP lab, of course, are some of the major polluters. And how can we understand this within the concept of reduce, recycle, and reuse? And if you're so inclined, go read this article, which kind of lays down some of the steps and how can we improve our environmental footprint and become more sustainable. One thing that we don't think about is how much patients drive to seeing us. And in Houston, this is a major problem, as you know, but also in the United States. So we mapped patients travel, every patient in the United States that has coronary disease, to the nearest cardiologist, assuming that they go to the nearest cardiologist, and assuming about 1 to 2 visits per year. So just cardiovascular patients seeing cardiologists in the United States once or twice a year, driving, is equivalent to about 1 million tree seedlings grown for 10 years, right, to offset that carbon footprint. This is not even pollution. We're talking about just greenhouse gas emission, right? This is about 75,000 acres of US forests that we have to plant every year to actually offset that. So the reason why I'm mentioning this is because telemedicine could be at least part of the solution here. I'm not saying that it's going to replace everything, but at least part of the solution, because if you were to replace 10%, 20% of your visits by telemedicine and reduce your travel, and of course, there's other travel that is related to staff and others, but for patients, given the vast majority of patients, every one of the 20 patients you see in clinic, it has driven so much and killed so many, trees and so on and so forth by their air pollution. So think about that, and kind of, that's part of the sustainability that we can do as cardiologists. There's actually some precedent to this. This is one of the silver linings of COVID epidemic, and you can see that in COVID they moved from telemonitoring of these devices, from in-person monitoring of these devices and interrogations to telemonitoring, and they estimated that they could save 32 million travel miles per year, and you can save 14 million pages of report that's printed, because Now it's all electronic, and you can actually save 200,000 trees planted for 10 years and 14,000 acres of US forests. So, and of course, there is a cost co-benefit to this, right? So some of these things can actually have a cost co-benefit even to the healthcare system. So what can we do as society? Again, cardiovascular disease is complex, but also it's complex within multiple systems. It's not just one system, it's multiple systems. So we can think about lifestyle changes, food systems, energy reform. We ought to do a lot of these as society, but also how can we understand urban redesign that can align with health outcomes? How can we understand as a healthcare organization, how can we improve risk prediction in climate education and healthcare organization? And hopefully this is part of this education piece here, but also how can we improve governmental policy changes? So in Europe and other parts of the world, there are some heart-healthy design cities that are kind of emerging to help improve cardiovascular health by improving access to green space, parks, and reducing travel and cars and pollution and so on and so forth. And of course, we should not forget about healthy, sustainable food system, because this is a major part of exposure and pollution in the United States and globally. So I'm going to spend the last 5 minutes talking about knowledge gaps and research opportunities. And a significant part of this here is really driven by what we have locally at Houston Methodist in the Houston area as well. So one of the things that has been missing in the basically practice of this, the people who design cities, they don't speak health, and the people who speak health, they don't speak design, right? So how can we really incorporate the two? And there is this concept of digital twinning where you can take a city and you can produce a digital representation in AutoCAD, for example, and you can take an individual, which is something emerging right now, from the EHR, and you provide a digital representation of that individual. And then combining the two, because we know where every person lives, allows us, using some of the emerging data science techniques, to really combine these and understand the impact of X on Y, right? So, and you can also impute and add some of the additional emerging tools, including some of the things that are still experimental but still conceptually very sound, including causal AI. There's generative AI and ChatGPT of the world kind of things. You can also understand in some specific cohorts the gene by environment intersection, and you can use some forecasting techniques to understand what is going to happen in the future. Now, none of this is a randomized clinical trial or meta-analysis, but this is the best we have because we learn from the past and we forecast the future, similar to weather forecast in a sense. So what can this approach help us with? Just to give you an example, it can identify community health trends and needs, which is actually something that all hospitals do, but do it in a primitive fashion. We could inform urban planning and nature preservation. We can understand personalized health recommendation, like I mentioned to you. For example, if you're low risk by X, Y, and Z, pooled cohort equation and whatnot, but this can actually improve this, then worsen your risk, then maybe we can give you statin, right? Guide tree canopy, and this is a major project, for example, that's happening in Houston, most urban areas that are designing tree canopy because you can do an intervention around that and you can actually plant trees. But where do you plant the trees? And you can understand this from some approach like this. So as you know, Dr. Nasser's kind of leading efforts here at Methodist, we have a huge EHR data that's very well phenotyped. And that's where basically we have not only EHR data and labs and vital signs and procedures and the CVD Learning Health System Registry, which includes 1.2 million people, but it also includes significant portion of raw data, including X-rays, MRs, coronary CTs, for example, right? Echoes, PETs, ECG signal. And now, with the capability of having geocoded all these patients, now we're able to link those with some of the approaches that I showed you earlier, including some of these data science or socio-environmental risks, including some of the Google Street View, Google Satellite Image Maps, and we can develop, using AI tools, now we can develop neural net kind of scores that can actually be potentially deployable in the EMR at the point of care. So one of these things, including this is an ongoing project right now at Methodist, where we're actually taking individuals and linking them with all of these metrics, noise, light, you name it, right? And develop really an individual level exposomic fingerprint that can be applied to cancer, it can be applied to heart disease, it can be applied to mitral valve prolapse, it can be applied to very different things which are often available to us, but we don't use them. So basically now we're moving from a zip code that is available in the EPIC system to an actionable risk prediction model that can actually also give you some actionable items. And using in silico models, these are computational models that can help you understand the impact of one intervention on a cohort of patients that can be simulated or real patients. This is some of the early phase kind of studies that we're doing here. This is a paper in review still, but basically looking at patients who have a history of cancer, which were geocoded and linked with walkability in Houston area. These are all Houston Methodist patients. And you can see that if you live in a highly walkable area, after adjusting for everything under the sun, you can see that you have a less incidence of hypertension, diabetes, obesity, and lower incidence of any risk factor. The same thing, will be presented in ACC. This is the same thing for PM2.5. This is in the Houston Methodist patient population, where it covers a lot of broad geographic area. You can see that annual PM2.5, if it exceeds the 12 limit that we set, then it has significant implication for MACE risk prediction with a hazard ratio that is significant and equivalent to what we do see with some therapies, and look forward to presenting this in ACC. So in conclusions, I'm going to give you 2 slides on conclusions. One is on the conclusions overall about this neighborhood and exposome. So access to parks and other environmental factors have significant role in defining as drivers of cardiometabolic health. Understanding the environmental impact is important to understand the residual risks to improve cardiovascular health in general. And also, emerging evidence supports that urban design supporting the healthy part of the exposome can actually improve our cardiovascular health. But also, healthcare has impact on the environment, which is something not as much talked about. And these complex loops can govern the relationship between cardiovascular health, individual health, and community health, and planet health. This is something called a concept called One Health, which I touched upon, but I didn't specify specifically during this presentation. And then also, it's no surprise that policy interventions need to be studied within the context of health. Urban design needs to be studied within the context of health because the health ramifications will oftentimes come back and impact the policies downstream and basically community health overall. The path forward from patient standpoint, all patients have to reduce carbon footprint because that's basically the way to move forward and keep the earth happy and healthy for our children and generations to come. Personal air cleaners and 95 masks for high-risk patients can be utilized. As clinicians, we have to assess environmental risks. We have to do better at understanding what is the residual environmental risk. We also have to educate patients. We have to educate residents, fellows, trainees on environmental risks of air pollution and other environmental hazards. From healthcare, we have to reduce waste, improve sustainability, invest in prevention, which is something that is not as much done elsewhere. And then carbon emissions have to be a priority. That's part of the ESG concept, environment, society, and governance concept. And society, we have to invest in clean energy. We have to move away from fossil fuel, and everyone, we really have to do our part right now because time is now. It's probably yesterday, but thank you.
Well, Sadeer, that was a fantastic tour on, I would say, uncharted territories and giving us an idea of what we really need to start thinking. And you touched on some practical ideas. The question, and of course, before we start, is what are the few things we can do to quickly incorporate maybe a social, environmental risk score into our management, and how long would it take, what would it take, and once we have that, how can it help with at least immediate management decisions?
Yeah, so that's an excellent question. And the problem is that people say we have a lot of risk prediction scores and nobody uses them, right? Every day there's a new risk prediction score. So how can we overcome the noise, no pun intended, in risk prediction and try to understand that risk, better and intervene on it? And I would say probably one of the main things that we do is we tag along the pre-existing risk markers, right? That's why I showed you this calcium score, because, for example, one could argue that, okay, I'm putting another number in the EMR, nobody's going to look at it, right? There's a full score equation probably built in the EMR, nobody's really looking at it. But if I give you a report of a calcium score, and I can say, listen, this is what we do, for example, in PET imaging, right? The short-term risk is low, but the long-term risk is high when you have a high calcium score. We could do something like that, where in the report of the calcium score, for example, we can say, listen, your calcium score, you're not going to like this. Your calcium score is 0, but your risk is probably still high because of residual inflammatory risk or residual expat risk, right? So not to put it somewhere else, but really contextualize the pre-existing risk scores that we often utilize. We've done about 50,000 calcium scores in the past 5 years. All of these can be actually developing the risk score is really not that difficult.
We probably could develop it in a week or two, and we can validate it in some of the external collaborators that we're working with. But I think that can be done fairly quickly.
That's the power of environmental scores. Thank you. Dr. Zak.
Sadeer, this was amazing. I think it's an eye-opener for all. I was interested a few years ago, obviously, when ACC positions and World Health Organization regarding pollution and effect, and that was a new learning curve for myself as to how important it is, and maybe even more important than others. So, and congratulations on really groundbreaking work and using the latest technologies, including AI, to hopefully intervene and alert people. I have two specific questions. One, mostly from a pathophysiologic point of view, if you will. These particular matter of 2.5 that we breathe and maybe swallow, are they throughout the body? Have people looked at from a mechanistic point of view, why do they affect cardiovascular system? I know there is inflammation, there are so many other things, but you would think they would be localized, but it looks like they may be throughout the body, so that's one. And two is, if I recall correctly from one of your maps of the United States, among the first or second map that you showed us where the heterogeneity of mortality, and it was mostly, although it was risk adjusted, it was predominantly in the southern belt, if you will, going all the way across. Yet, when you showed us the map of particulate matter of 2.5, it was almost the reverse, and I couldn't understand that.
Yeah. All right, sounds good. So, two difficult questions. The first one we can answer fairly straightforward. I think for both, we don't know what we don't know, okay? We know what we know and we don't know what we don't know. That's the problem with this field. But I would say that there are studies in these particular matters. When we say 2.5, it means everything smaller than 2.5. There is ultrafine particulate matter. So there are actually studies where people have inhaled, David Newby and others have done these studies where they gave people inhaled kind of type of ultrafine particulate. And they looked into the organs to see where they are. And actually they do deposit. These are the ultrafine ones. The problem with ultrafine, they change in temporality and spatiality significantly. So it's not easy for me to assign what your exposure is today, because the models that we do have, other than maybe personal monitors, we don't have a good way of assigning this. So the field is emerging about ultrafines. The vast majority of the effects that we do understand right now about PM2.5 specifically is driven by intermediaries. So for example, what we do know is the vast majority of PM2.5 particles, they don't translocate into the blood, but they do have local effects, probably at the lung parenchyma, that leads to, from local to systemic inflammation, some signaling that can eventually have dramatic effect on all the organs. So in animal studies, when you have controlled experiments in mice, and you expose them to PM2.5 at levels that we do see in Beijing, Delhi, you do see a significant epigenetic reprogramming of almost all the organs. Some of these effects do overlap with high-fat diet, right? So some of the effects could also mimic what we get with high-fat diet, which is the primary exposure that we do in mice, as you know, right? So the high-fat diet is when we try to get atherosclerosis. There's a lot of epigenetic markers that get upregulated and downregulated that mimic the same fingerprint that we do see in that. We do see also, as I mentioned, systemic inflammation markers in controlled studies. They used to do these diesel-controlled experiments in humans in the ICU. They give them diesel and so on. And this is no longer quite ethical yet now because the field has evolved. But now we're moving into air filtration intervention in a randomized fashion. So basically you take people, put them in a slightly polluted environment, and then you randomize them to air cleaners. And we do see significant impact on CRP, IL-6, everything that you've heard in the past 6 weeks, and ground rounds, really. So there are a lot of effects that do happen beyond the lung inflammation. There's also something emerging right now that it actually does impact your circadian rhythm, and it may have a direct impact through the olfactory nerve directly to the brain. This is, as you can imagine, this is difficult to study right now, but it's because there are effects on stress and so on and so forth. The second question was about the co-localization of PM. And what the story, when we show these maps, they're static maps, right? But I showed you in one of the curves that actually in the lower exposure, you have a more steep relationship between PM and cardiovascular disease. So some of these relationships, yes, it's true that there are other factors, right? Of course, if I come to you and tell you that 100% of cardiovascular disease is mediated by PM2.5, you'll probably fire me tomorrow. But I would say that there is a small proportion of PM2.5 that can be, overlapping between cardiovascular disease and PM2.5. And it's probably the areas that have low exposure, similar to what we have, relatively speaking, in Houston, that have the significant impact because it's attainable to reduce that PM2.5 from the 6, 7, 8 level to 3, 4, 2. It's very attainable as opposed to from 100 to 2. But also it has significant more impact because you sit on that curve that is a little bit more steep, if that makes sense. Yeah.
Dr. Shah.
Great. So, Sadeer, first off, we're very happy to have you here. Welcome. I think this was a tremendous presentation. I think it's very innovative, the work you're doing, and really kind of using cutting-edge techniques to really be able to do this. So I want to congratulate you for this, and I actually look forward to hopefully learning more about some of the stuff you're doing. So I found actually very interesting the one analysis you did from the SPRINT trial, where you actually then stratify the patients based on what their environmental exposure was. One of the things I found interesting in that analysis was it seemed like the ones that are in the high exposure area or high pollution region, they had a significant relative risk reduction with randomization to treatment, but they actually ended up with a better overall rate compared to the group in the lower risk. Right. And that's kind of paradoxical to me. So I'm curious what your thoughts are on that.
Yeah, no, you touched on a very strong, important point. And I think that's one of these problems with these epidemiologic studies, right? The interesting thing that you're right to the point that we did not see, although it looks as if they're better, they're not really better, they're exactly the same. So if you were to plot the relationship between PM2.5 and cardiovascular events in the entire SPRINT trial, there was no relationship, right? It's relatively small trial, relatively small number of events, so we were not disappointed by the lack of relationship between PM2.5 and the absolute number of events, because that has been established in multiple studies. But you're right to the point that if you were to look at the placebo, it was not different between the two. What was different is the intervention, well, not the placebo, but the usual care was not different between the high PM2.5 and the low PM2.5, but what was different is really the intervention arm, the intensive intervention. And it's still work in progress. It's hard to know what really is responsible for this. But I can tell you that, of course, we were skeptical of the results, but contextualize it in the context of the limitations of the study. But I can tell you that we have a very similar analysis using 2 randomized trials of somewhat similar intervention, not quite, but somewhat similar intervention, and we see the exact same thing. We don't see the positive interaction, but what we do see is that there is a significant reduction in number needed to treat if you are exposed to higher pollution, which kind of makes sense, right? You do see that air pollution increases the baseline hazard or the baseline risk, and you don't need as much to, to treat to actually cause a significant reduction in cardiovascular events. So that's still work in progress, but you can imagine the complexity of dealing with randomized trials that have, I wouldn't recommend going into this field.
Any other questions? Well, thank you so much. I think so this was a fantastic insight, Sadeer. We look forward with you in how we can incorporate all of this within our care pathways, but more importantly, as a health system, I was very intrigued and love to hear more at some point on, as a system and cardiology especially, what can we do to reduce our carbon footprint? Thank you. Thank you.